everybody. I'm Katy Lees, Principal 340B Compliance Advisor with Virtue 340B. Welcome back to the next installment of my video series, or if this is your first time joining, thanks for joining. I'm glad to have you. I thought today we would dig a little deeper into duplicate discounts. It's such a hot topic, can be a very complicated topic, and something that we all really need to be very aware of if we're participating in the 340B program. It is certainly a point of contention with other stakeholders in the industry. So just a very important element to understand, just all the aspects that go into duplicate discounts, how they occur. So I just thought we'd run through a bunch of points today and I don't necessarily have all the answers, but I thought if we talk through just some of the highlights and maybe give you some things to think about. Certainly if I miss anything or you have any questions, feel free to submit them as follow-up. So just again, for some baseline, let's run through super quick what a duplicate discount is when it comes to the 340B program. So as we talked about, or as most of you are probably aware, the 340B program and the Medicaid program are fairly closely aligned. So the Medicaid program receives rebates from the pharmaceutical industry based on prescriptions or medical claims that are paid for drugs. And some of those drugs may be fulfilled, those prescriptions or those medical claims may be fulfilled with drugs that were purchased at the 340B price. Now, a duplicate discount occurs when a covered entity makes a purchase, receives a drug at the 340B price, administers it or dispenses it to a patient that ultimately that claim gets billed to Medicaid, and then Medicaid claims the rebate. So now we have the entity getting the discount and the Medicaid program receiving the rebate. So that is a duplicate discount. That is something that cannot occur or should not be occurring. And the way that this is prevented is by the covered entities understanding the rules and taking steps to notify Medicaid if they are using 340B drug so that Medicaid then does not claim the rebate. So I don't know if that sounds simple. I'll say if it does sound simple, it definitely is not simple putting that into practice because there are a lot of ways that we bill Medicaid or settings or scenarios when a prescription or a medical claim is billed to Medicaid. And so I thought we'd run through a few of those scenarios. And I also want to give the disclaimer that the term duplicate discounts is out there and discussed a lot in the 340B program or pertaining to the 340B program. And sometimes it's not always referring to a Medicaid duplicate discount. So covered entities are required to prevent Medicaid duplicate discounts, and really more specifically fee-for-service Medicaid, but it's pretty well known and accepted that this Medicaid duplicate discount is both fee-for-service and managed care Medicaid. So that's when it's on a covered entity to make sure that duplicate discounts are being prevented. There are many other scenarios where a duplicate discount occurs that does not involve Medicaid, that I'm not saying that it should happen or is good that it happens, but those are different than this, the regulatory requirement that we prevent Medicaid duplicate discounts. So that's what I'm focusing on today. And just since I mentioned it, so there could be commercially paid prescriptions or medical claims where a 340B drug is used, and there are rebates that are occurring in the background. So there are duplicate discounts, but that's really not anything that the covered entity is required to prevent, or maybe even has any insight into happening. I know that TRICARE is another some government payer where there are some rebates, but again, it's not part of the Medicaid program, so it's again, not a regulatory requirement to prevent it. And then there are some other scenarios. I know in New York State, we have a senior plan. It's referred to as New York State EPIC. And there are rebates that are exchanged in that regard as well. But again, it's not part of the Medicaid program. So not what I'm talking about today. We are just going to focus on Medicaid duplicate discounts and the key points that you want to know. So I will start with talking through when you make the decision. So when a covered entity registers for the 340B program, part of the registration process with HRSA is to decide and declare if you're going to use 340B drug for Medicaid patients. So on my screen, you see the Office of Pharmacy Affairs Information System, or 340B OPACE. So in this platform, you can find all covered entities in their registrations. Okay, so the first covered entity that comes up, you can see, I'm going to click on their 340B ID. And you look through here, if you scroll down, you'll see Medicaid. So you can see here that this site has opted to carve in Medicaid. So at this site, will the covered entity bill Medicaid fee-for-service for drugs purchased at 340B prices? And they have said yes. And so as part of this, they have declared that in 3 different states, they are carving in Medicaid, and these are the billing IDs and the NPIs that will be utilized. So this is one place that you need to make sure, if you are the covered entity, you are appropriately reflected here. Or if you are someone else that wants to know about a covered entity, this is a resource for you to come look and see how they're handling Medicaid. Now, the more popular place is to go to this reports tab. And now if you go to this Medicaid exclusion files, this is going to give you, you can run it for different dates. It's going to default to the most recent quarter. It's going to give you an Excel spreadsheet that lists every single covered entity and their child sites if they are carving in Medicaid with their billing IDs. So this is a very important resource. Again, if you're a covered entity, you want to make sure that you know about this and that you're reflected properly and that your practices are matching what it says here. But if you are another stakeholder in the space and you're trying to figure out how a certain covered entity is handling Medicaid, this is also a good resource. This is all publicly available information. I have not signed in to the OPACE website. Anyone can come here and get this information. So that was the first part that I wanted to talk about. So that is if you want to, again, carve in Medicaid, you would answer yes. And it will reflect your billing information on OPACE and on the Medicaid exclusion file. Or if you answer no, that means that you are going to carve out Medicaid. You will not be using 340B drug for your Medicaid patients, and your information will not be listed here. Now, very important that there is work to be done if you are opting to carve out. You need to make sure that you have systems in place to not use 340B drug for Medicaid patients, because it's certainly not, you don't carve out by default. So steps will need to be taken to make sure that in whichever setting you might be using 340B drug, that you are not using it for patients that will be billed to Medicaid. So that was my quick carve in, carve out. Some other things to think about, when you're thinking about billing for Medicaid, Medicaid could be the primary payer or Medicaid could be the secondary payer. So there might be slightly different billing requirements. I know in New York State, if Medicaid's the primary payer, you have to bill at acquisition cost for fee-for-service Medicaid and put the identifiers on. And then if Medicaid is the secondary payer, you're not billing at acquisition costs because most of the time you're submitting a copay to Medicaid, but you do still have to put those identifiers on because they will still claim a rebate even though they're not the primary payer. So it's very important to make sure that you're putting those claim level identifiers on. And one thing that is not always super straightforward in the billing process that I've had some experience with is when a patient is dual eligible. So if Medicare is the primary payer and Medicaid is the secondary payer, sometimes the entities are not billing Medicaid as the secondary payer. Sometimes that claim just gets passed along by Medicare. So a claim is submitted to Medicare and then Medicare passes that along to Medicaid. Now that is still on the covered entity to make sure that you're aware of that process and that you're putting the appropriate identifiers on the claim so that when it reaches Medicaid, they know that 340B drug was used. So this is most common in, I'll say, the facility administered setting, where it's the medical coverage is paying for the claim. But this also can happen in the outpatient pharmacy setting where there's certain drugs that the medical benefit would be covering the prescription. So definitely, again, something to be aware of in just making sure that you know all of these scenarios where a duplicate discount can occur. The other not so straightforward piece is out-of-state Medicaid. So if you are on a border state, you are near the border of a state, you might be a little bit more familiar with, what's happening if you're billing Medicaid in a border state, something like that. But even if you're not, if you're especially in a large institution that may see patients from other areas, you really want to make sure that you have an awareness of your out-of-state Medicaid billing, when this might occur, and how you're handling your prevention of duplicate discounts. Because it's probably the safest thing, I will be honest, is to make sure that you're not using 340B drug for these out-of-state Medicaid plans, because it can get complicated to keep up with what the different policies are by state, to make sure that they're going to recognize, if you do put a modifier on, are they going to recognize that? If you have your billing numbers reflected on the Medicaid exclusion file, but you only have your home state listed, even if you're using those same IDs, are they going to look to that information since you don't have the out-of-state listed as, somewhere that you would be carving in? There's just a lot of complicated factors that come into that. And I will say, even if you're not getting paid by this out-of-state plan, just the way it looks and flows in your own system could be problematic. Upon a HRSA audit, if they see that you're billing in out-of-state Medicaid, then that could just be problematic, at least at face value. Ultimately, you may do the research and there was no rebate claim because there wasn't a paid claim, but save yourself the trouble, spend some time and figure out how you need to manage out-of-state Medicaid within your covered entity. Because like I said, it can get kind of complicated. And I had another resource that I wanted to share. There is, I think I mentioned this before, so Apexis has a great website. I pulled it up, I have it on my screen here. So if you go to the 340B Prime Vendor website, again, I am not signed in, this is publicly available. This is a good reference tool if you're trying to understand what the 340B policy is in different states. So you can pull up any of the 50 states here. I'm going to go to New York because I know that they have something listed. So here you can see what the basics are for New York State. First, it has some important contact numbers. And then it lists out and again, this is all publicly available. That's how Apexis got it, but still great that it has it all in one place. So if you click here, you can see what the retail pharmacy prescriptions, what the requirements are, the facility administered requirements, MCO information, and then it mentions a contract pharmacy policy. So if you're looking around, you might see that not every single state has these rules listed. Here I pulled up Maine. And again, it has some contact information. Doesn't look like Maine has much published, or at least it hasn't been translated here to the Apexis website. But here it says, Maine Care does not allow contract or retail pharmacies to enroll in the 340B drug program, either directly or under subcontract. So I guess that was our answer. And then it does have some other information here. So again, a great resource if you're trying to figure out how to handle how to prevent duplicate discounts by state. I also just pulled up here to show, so in New York State, here's our policy. I just once in a while I'll Google just, New York State Medicaid 340B just to see if, what's been updated. This is the most recent update from February 2024. I don't know that it has any new information. But always good to keep up on this. And again, it has all of the contact information if you needed to get in touch with someone for New York State Medicaid. Because if you do think you have a duplicate discount issue, in my opinion, the best way to approach that, aside from, doing an investigation and figuring out exactly what the scope of that issue is within your covered entity, I like to reach out to New York State Medicaid and just get the information, what rebates did you claim for my covered entity, so that I can compare that to where we use 340B drug and where we didn't, so I can really zero in on those duplicate discounts. So it's good to have a relationship with your the folks at your New York State Medicaid program. They will be a good resource. All right, so where should we go from here? What else do we have? I guess that was about all that I wanted to cover today. Again, very high level. I just wanted to share some resources that I always find helpful. This whole Medicaid and duplicate discounts, that intersection with 340B, it can get complicated. It's not straightforward. There's not one place, one setting where this is occurring. This is when you're administering drugs in your facility, if you're dispensing prescriptions from an outpatient pharmacy that's owned by your covered entity, or in the contract pharmacy setting. It looks a little different in each place, and you might carve in or carve out depending on that setting. Maybe in your facility administered meds, you're carving in. So you want to make sure that you understand what the rules are for that type of billing and that you have systems in place. Maybe at your hospital outpatient pharmacies, you just don't have the capabilities of putting those claim level identifiers on at the time of adjudication. So you have to carve out in that setting. Or maybe you can do that. So you carve in for your hospital owned pharmacies. So again, you want to make sure that you have a system in place so that that's putting those claim level identifiers on. And then in the contract pharmacy setting, it can be really complicated to include Medicaid. So I think the majority of the time, covered entities are opting to carve out. But again, that carve out is just not by default. You need to make sure that you have a system in place. If you're working with a separate vendor, make sure that you have any of those payers listed to be excluded if Medicaid is the primary or secondary. And not just fee for service. If you have managed care Medicaid in your state, you want to make sure that you're on top of that as well. So, you want to look at each setting in all of these categories. Like I said, Medicaid primary, secondary for your dual eligible patients, out-of-state Medicaid. You're going to want to look at all of those areas in each setting and how they're being handled and make sure that you have everything set up appropriately. And then you're going to want to make sure you're checking it periodically. You definitely want to have a monitoring system in place. Have a person that once a month is reviewing a sample of these and those results are as you expect. And maybe you also have a process where you check in with your Medicaid program periodically and they send you a report of rebates and you do a double check that way. It's definitely not a set it and forget it kind of thing. So yeah, there's a lot to think about, and I hope this was more helpful than stressful. But again, if you have any follow-up questions, I would love to hear them, and I will talk to you soon. Thanks, bye.